sorry for our car passed away, and I want to give my gratitude to my mentor, Professor M.M. Bari sir, and I want to go to my topic now.
Yes, Mostofa, continue.
By doing this lecture, learn about the basic principle of the wire introduction, appropriate technique of wire induction, to know about the fixation of the wire with ring, and to know about the additional connecting elements like boards, nuts, bushings, threaded sockets, and different type of washers. Type of wires. So we are usually use the wire as diameter of the wires are 1.5 millimeter, usually used for the children, and 1.8 millimeter for usually used for the adult. For cortical bone drilling, their wires with bayonet tips we use. Here in the picture, number B and D show the bayonet tip, and for cancellous bone drilling, we usually use.
Mostofa, please unmute your microphone. Mostofa?
Okay.
Yes.
Okay. Can you hear me?
Yes, yeah, I can hear you.
Okay. For cancellous bone drilling, we use the Tucker tip shown in the A and C figure. And we also use the olive wires in figure E and F. Now, basic principle of the wire introduction. There are some rules for the introduction of the wire we should keep in mind. Number one, wire entrance and exit sites. The introduction of the K wire of the entrance and the exit sites are predetermined by the surgeon, while the surgeon is positioning at the wire or drilling the wire through the opposite side of the extremity. An assistant should point to the expected exit site with a finger or an instrument so that the surgeon can direct the wire exactly towards that visual marker. Must be
there may be some.
Usually are located.
Yes, continue.
Within the intermuscular septum layers and are easily movable within the range of 0.5 to 1 centimeter. So 1.5 to 2 centimeter apart from the major vessels is safe. Number 3, guidance system is useful in the wire positioning. Any wire has to be positioned according to the ring plane and preferably cross only one side of the ring wall, either proximal to proximal or distal to distal. A guidance system, particularly the slotted fixation bolt, is useful in K-wire positioning. Once the proper ring hole has been chosen for the bolt, proximate the wire entrance, the wire can be placed in the groove of the bolt head and directed parallel to the ring wall. Rule number 4, slow introduction of the wire. The wire must be introduced slowly, pausing several times during procedure to avoid burning of tissues, particularly bone and skin. It is recommended that the low power drill should be used. And low power drill helpful to avoid injury to the vessels and nerves. Rule number 5, at the entrance and exit sides, the skin must be supported by fingers. The skin surface is manipulated according to the type of procedure being performed In transfixation of the extremity with non-movable ring, the skin is held firmly and perpendicularly to the underlying tissue. In plant destruction, the skin should be pushed towards the site of the corticotomy, and in plant compression, the skin should be pushed away from the site of the compressed ends. Shifting of the skin in this manner prevents it from being cut by the wire during the course of destruction compression, and also prevents additional pain and unnecessary scar formation. The muscles must be kept in a position of maximal functional length to prevent joint contracture. The closer the wire insertion to the joint, the more attention should be paid to this principle. With the distal tibia, the foot must be placed in plantar flexion during wire penetration of the muscular muscles of the anterior compartments, and then must be put in a position of the maximum dorsiflexion during the insertion of the wire through the posterior compartment. It is also preferred to keep the knee flexed during this ankle wire introduction procedure. Like this, in case of the femur near to the knee joint, when we introduce the wire from the posterior compartment, the knee should be extended, and the anterior compartment, the knee should flex. And rule number 7, the last rule: one wire, one hole. Each wire drilled through the bone must be introduced correctly at the first attempt. Multiple holes resulting from the incorrect wire positioning destroy compact bone through mechanical damage and through burning. And this destruction can resulting in wire fixation weakening. Multiple drilling through the bone marrow significantly destroyed it and blood circulation, causing hematoma formation, delaying its ability for new cell development, and may even contribute to infection. Now come to the surgical technique. The tip of the wire is introduced through the skin by simple puncture through the skin, fascia, muscle, and up to the bone, not by drilling, only puncturing manually. It is useful to slightly move the tip of the wire up and down transversely to the bone surface to ensure that the tip is not on the bone slope and will not slide down when drilling the wire through cortex layer is begun. When we reach the cortical bone, then start drilling with low speed drilling, and to avoid bending and to maintain a straight trajectory and to decrease the temperature or heat produced during drilling, we can use a wet sponge, can be gripped at the entry point. We wetted the sponge by alcohol, or maybe chlorohexidine also can be used. Ideally, the wire is drilled through bone sides of the cortex, passing through the bone canal and bone marrow. Transmedullary wire insertion rather than cortical insertion is important because it provides greater wire stability and helps prevent cortical osteomyelitis. When the second side of the cortex has been penetrated, drilling is terminated. And at this moment, the surgeon must try to pull the wire backward slightly. If it is firm and unmovable, the wire is in the correct position. If it pulls back easily, the direction of the drilling must be changed. After passing the far side of the cortex, the drill is disconnected And wire insertion is completed by hammering with light taps to prevent perforation of the major vessels and nerves. And this in this time, when the wire tip approaches to the surface, the skin at the exit site must be manipulated in the same direction as at the entrance site. Wire insertion is continued until the amount of the wire is approximately equal in both sides. In case of olive wire, a 0.5 centimeter skin incision must be made at the portal of the olive stoppers wire with number 11 blade. Wire positioning on the same ring. It is better to insert the wire in 90-degree angulation, but practically it is always not possible. What happened if we introduce the wire in parallel? There may be ring may be move either side of the bone. Even in 30-degree angulation also there may be movement of the ring. So it is better to use a greater angle, more than 30 degree. And now ring should be brought up to the wire, but wire should not be brought up to the ring. So to brought the ring up to the wire, we can use many things like washers or other supports. And relationship the wire and ring connector. A wire should be fixed as close as possible to the ring connector on a ring. The closer the wires, the less the axial loading they will bear. This prevents the formation of a large hole in a bone cortex, resulting from axial loading pressure, and also prevents wire breakage. Wires with stoppers. In the beginning, the jet-shaped stopper was used, but it was not good for the soft tissue. Nowadays, the olive stoppers are used, and sometimes we use washer where needed. And this stopper is used for bone fixation, bone fragment displacement reduction, bone fragment deviation correction, technique of bone fragment pooling in an internal transport, interfragmentary compression, and in osteoporotic bones, sometimes with washer. Affixing of the wire to ring. The three possibilities wire ring hole position are: wire over the middle of a hole, wire near the edge of a hole, or wire between the holes. So we use cannulated wire fixing bolt when the wire is middle of the hole, and near the edge we use slotted wire fixing bolt, and wire is situated between two holes, we use buckle. In some cases, wire fixation must be performed away from the ring wall. In this situation, a combination of support is introduced into the nearest available hole and is brought to the wire, but not vice versa. Wire cutting and bending. It is also important. Cut the wire immediately after introduced, before tensioning or fixation with ring, because it helps early cutting. It helps to prevent injury to the surgeon as well as assistant. Both ends of the wire, approximately 5 to 6 centimeter, must be left free for future tensioning, and both end are bent into loops wrapped around the ring, and their tips should be kept underside the ring so that it can't harm the patient or the physician. Now the auxiliary parts, the bolts and nuts. There are three types of connecting bolts: 10 millimeters, 16 millimeter, and 30 millimeter of length. And there are some uses of the bolts. And nuts, there may be three types of nuts: 3 millimeter, 5 millimeter, 6 millimeters. Usually 5 millimeter is better, and when a compression destruction frame is there should be 6 millimeter diameter nut. And this figure shows the one full length rotation causes 1 millimeter of length. And wire fitting bolts, I earlier mentioned that there may be centrally held or cannulated and serrated or threaded socket and bushings. These are also helpful. These are usually used to connect the different rods. This is bushing, and there are various type of washers and their uses shown in the figure. So stay home message: stay home and stay safe. The wire is the part of the Ilizarov apparatus that determines how the treatment proceeds and the result. Basic principles, or which I mentioned in the rule of 7 or 7 rules, should be kept in mind during wire insertion. Appropriate surgical technique should be applied. The wire should not be brought down to the rings. Rather, the ring should be brought up to the wire. Additional connecting elements like bolts, nuts, bushings, threads, sockets, and different types of washers should be used meticulously. And next 31st this month, wire tensioning, tensioner and thermal necrosis topic will be presented by Mohammad Kamruzzaman. Thank you. Thank you all.
Thank you, Mostofa, for your nice and elaborate presentation. Especially, you are very much meticulous about the wire introduction and what are the anatomical consideration and other thing. And you presented it very elaborately. And now I am just handed over microphone to my professor Mofakarul Bari, so that he can pass some comments about the presentation. And after that, I will go for the next part of my presentation that will be delivered by mine. And I'm requesting Dr. Bari sir, please unmute your sir. Can you hear me, sir?
My microphone is.
Yeah,
Can you
yes.
hear me? Hello?
Yes, sir. We can hear me. Sir, please pass some comments about our today's first presentation. Then after that, we will go to the.
Thank you, Mostofa.
Thank you, sir.
Yes, yes. Nice. Can you hear me?
Yes, sir.
I
We
can.
can hear you.
So nice talk. He mentioned everything almost, and nicely mentioned. For Ilizarov surgery, instruments properly. And basic instruments, if you don't have any idea, that you cannot culture your brain. Instrument always will help you to proceed further. And if you have have any good idea regarding the every instrument, time to think yourself how to use this one. You could utilize another one. With these sockets, you can apply the tensioning properly. If you cannot get any space to put your particularly, then you can utilize this socket and it will help you to tension the wire properly. And striving force around the ring must be equal if you use the whole ring. And regarding the basic principles, elaborately further. Now I would like to invite Dr. Arif to continue his lecture. Thank you very much. Thank you.
Thank you, sir. I'm going to the second part of the presentation. And so far, 25 people joined in our session. And many of the foreign participants, we are just seeing in our list, many of the foreign participants from India, from Nigeria and other part of the world. I welcome them all today's presentation. And now the second part of the presentation will be conducted by me. And one more important information for if you miss the lecture, don't worry, then you can go to our YouTube link and you can enjoy the lecture as well. And usually due to some technical difficulties and other difficulties in connection in the webinar, sometimes you may miss any part of the webinar, so you can enjoy it in the website. And one thing I want to announce today that some of our very good Indian friend, Professor Samsul Huda, is from India. He is the administrator of Ortho World website, and he shared our link and web and YouTube link in his website, and so that the many of the Indian audience can link with us in this webinar. So it is very prestigious for us, and I think hopefully you should enjoy all the session. And you know that we have more than 20 sessions in this, and this is very basic thing for the beginner. Even the senior and the most efficient surgeon also can refresh their knowledge and some basic details about the Ilizarov. And now another thing is that Dr. Mostofa, he is also co-host of this session. And Dr. Mostofa, as I am delivering my lecture, so you can please handle the participation list. If anyone waiting for joining, please admit them. You have the right to do this. I already permitted you as a co-host. So now I am sharing my screen, and I think hopefully you can enjoy my lecture.